All right, chapter 43, musculoskeletal system, the introduction. If you remember from before, introductions have a lot of information, mostly about things like tests, drugs, and procedures. So it's going to have some tables. I'll be pointing out important information in those tables and drugs. So I want you to take note. So please have your book with you for this because I'm going to talk right from the book. And there's some pictures in here. We're going to look at the pictures. And it's very interesting. Gosh, we use this system every day. We don't even think about it because we use our musculoskeletal system all the time. So let's get going. So the first thing I want to talk about, notice I've got page numbers here. So this page number starts on page 844. So under each header is going to tell you the page number so that you can hang in there with me. Because there's not a lot on the slides. In fact, there's only 9 slides, but a lot of talking. So hang in there. All right, so let's talk about how many bones do we have? How many bones? I bet you learned this in fundamentals, maybe even A and P. But I bet we don't remember. So I'll say it, 206 bones. Amazing. So what comprises connective tissue? Because the next chapter is connective tissue diseases. So what 4 things are going to be involved in connective tissue diseases? Now that's right here. Bones, cartilage, ligaments, and tendons. Now that's really important to know about those 4 being connective tissue diseases. Yeah, we've got some joint issues and some other skeletal issues, but those are going to be thrown in. But we need to know connective tissue diseases are bone, cartilage, ligaments, tendons. Okay, said it 3 times, must be important. So 206 bones, and bone is the hard tissue that makes up most of the skeletal system. The function of the bones is to support, protect, move, have calcium and other ions, and manufacture blood cells. Now we've talked about that, what bones do, how they make blood cells before. Now cartilage. What is cartilage? Well, it's a special fibrous connective tissue. It provides firm but flexible support for the skeleton and part of the embryonic skeleton and part of the adult skeleton. It differs from bones in that its matrix has the consistency of firm plastic or gristle-like gel. Have you ever eaten like some chicken and got grizzle? You know, that's cartilage probably that you're eating or trying to, that you're chewing. So, ligaments. Ligaments are strong, flexible, fibrous bands of connective tissue that link the bones and cartilage and support the muscles. There's yellow and there's white ligaments. Yellow ligaments are located in the vertebral column, and they're elastic and allow for stretching. White ligaments connect articulating joints. Now, what does that mean, articulating? It means that they move. They move around. And notice that's the knee that provides stability. And it doesn't stretch, but it moves around. So does the hip, kind of flexes around. So does the shoulder, flex around. We can move it back and forth, up and down, around in a circle. Then we've got tendons. Tendons are composed of strong, dense, fibrous connective tissue. They're in the shape of heavy cords and anchor muscles. Probably one of the most prominent tendons that you can think of is your Achilles tendon. And if you're a basketball watcher, if you like to watch basketball, sometimes the basketball players injure their Achilles tendon. And boy, if they hurt that, they are in big trouble. And sometimes they'll rupture it, and their just whole leg just kind of collapses because that Achilles tendon helps hold that leg upright. So let's move on to joint structure and function. A joint is the site at which two bones meet and join, and they permit motion and flexibility of that rigid skeleton. Now, the only bone that does not articulate with our other bones is the hyoid bone, to which the tongue is attached. But also, you've maybe heard the word hyoid bone when they've talked about, I'm going to just say something that's been in the news, Jeffrey Epstein. So when he was strangled or hung himself or whatever happened to him, his hyoid bone was cracked because that tongue does attach way to the back and into the neck. So it does kind of stretch back. All right. So classified on the basis of the extent of movement, joints include fixed joints or synthrosis, slightly movable joints, amphithrosis, and freely movable joints, diathrosis. Like synthrosis is something like the skull, where there's no movement at all. And then you can just read examples of the amphithrosis, the ulna and radius of the forearm. So if you hold your arm straight out and so your thumb is facing upward, and you just rotate that thumb forwards and backwards, what you're doing is moving your radius. And that's because you're doing a radial movement with your thumb. And that's a good way to remember which bone that is. That's the radius. And then, of course, the other is the ulna that kind of just tags along. So those are good movable joints. Then we've got diathrosis, synovial joints, found in the elbows, shoulders, fingers, hips, and knees. And they allow for a lot of considerable movement. Of course, that makes them at risk for getting some injuries in that synovial fluid, which we'll talk about later. But I just kind of want you to get that picture of what's going on. So they're encased in a fibrous capsule made of strong cartilage and lined with the synovial membrane. So let's go to that figure 43.1 that the book refers us to. So let's go up to classification of joints. So there's what the different types of joints look like. So A is your skull, which is not movable. B, which is your spine, the cartilage in between the vertebrae that helps provide cushion. And then you've got, in C, there's some cartilage in the pubis area that allows for your movement. And then you've got D, which is your hip. And you can see there's cartilage there that helps allow for movement for your greater trochanter or your hip joint. And then go on down to E, which is your knee, where your femur, and what's that bone on the bottom called? Can you remember? Well, anyway, think about it. I'm going to leave you something to think about. All right, but what I want to also mention is that in E is, I see the patella. The patella is your kneecap. I think that's interesting bone because, you know, when babies are born, they don't even have a kneecap. And until they're probably 2-3 years old, they don't even get a kneecap. It's probably so they can crawl easily, you know, without hurting their kneecaps. But nonetheless, that's something that comes along later, kneecap. Now let's talk about the skeletal muscle. So the skeletal muscle is primary function is to contract and cause movement. Muscles work to keep joints stable by preventing excess movement of the bones and joints. Skeletal muscles also protect internal organs, particularly the abdominal and pelvic organs. Skeletal muscles are located throughout the body, and they're something like voluntary control of functions like swallowing, urination, defecation. And the only way to functionally contract a skeletal muscle is through signaling from the nervous system. That's interesting. Also, skeletal muscle contractions are either called isometric or isotonic. Isometric contractions increase tension within a muscle, but don't produce movement. So like we can do kind of tighten up our muscles. It's an isometric exercise, tightening up your muscle. I'll do that in my legs. Why don't you do that too? Tighten your leg muscles, your hip or your thigh muscles, just tighten them up as tight as you can, tight as you can. Isometric exercise, and then relax them. And you know, really that does help tighten your muscles. Then we also have the isotonic. And isotonic contractions produce movement. Immobility reduces muscle contractions and can produce muscle atrophy, which we don't want to have happen to our patients because that's a decrease in size. Atrophy means they kind of shrink in size, and then that limits their movement. That's why range of motion in our patients is so important, to keep that range of motion going. And we talked about that in last chapter, how important that was. So a layer of fascia called the epiphyseum covers skeletal muscles, and individual muscle cells are bundled together by collagen to form a fascicle. Now, I'm really going to have issue with some of these next words. So let's turn the page. Oh, wait a minute. Let's go back to figure 43.2 because I just want you to see what a joint looks like. The two bones, and see the kind of spongy material at the end of the bones. You know, that's where we make our cells. That's the epiphysis is where our bones grow from, and that's at the very end of our bones. And then you can see the cartilage in the middle there, the capsules, the synovial membrane. So I just wanted you to notice that. Okay, now we can turn the page. Now there's a big old picture of a muscle right there, figure 43.3. So each muscle cell has names, of course, names that are hard to pronounce. Latin. Usually everything comes from Latin. Fiber bundles are covered by perimysium and an inner layer of connective tissue called endomysium. But I'm going to kind of jump from that because, okay, there's your muscle. That's what it looks like. It's not going to be that important for you to know which layer of muscle is used. Just know that there's many layers to it. Let's go down to age-related changes in the musculoskeletal system. So I'm just going to change the slide here. And we are on page 846, and we're looking at age-related changes. And let's look in the box. So the box 43.1 has age-related changes, like loss of bone mass and density. So what would we call that? Oh, it's up there on the slide. Sorry. Osteoporosis. And osteoporosis is common in women. It can affect men, but it's more common in women. We're going to talk more about osteoporosis in the next chapter. And then the older patient is at risk for fractures. So that's why that chapter of falls and immobility, both of those chapters are very related to this chapter because falls can cause broken bones and injuries. And then lying in bed can can cause loss of bone mass, and then lack of movement or immobility can lose mass and strength. And then the older patient is at risk for fractures. So falls, if they fall, easily fracture their bone, and that's because of, go to the other word, osteoporosis. Makes it easy, especially for women, to have fractures. Okay, so cartilage gradually loses elasticity. Water content decreases and cartilage may ulcerate, leaving bony joint surfaces unprotected and promoting growth of osteophytes or bone spurs. And that can result in pain and limited mobility. So let's go back to the book for a minute. Just want to be sure we covered everything. And we did. So age-related changes can cause pain, limited mobility, impaired function. It contributes to a loss of independence because if they can't move well, then they can't get around very well. And if they do try to get around, they might fall. And when we lose our independence, we lose some self-esteem. So we've got to be aware of all of these things in our patients. So we looked at the list of changes. So let's go back up to our age-related changes in box 43.1. So the loss of bone mass and density, decrease in bone strength from the osteoporosis, loss of elasticity and water in the joint cartilage, resulting in softening, fraying, and ulceration, loss of cartilage in joints, resulting in osteophytes. Now, I'm well aware I just said this again, so I hope you are aware also. So I would like kind of make that box 43.1 something important to remember. So it also causes a decline in muscle mass. So you'll notice that some of the elderly, they look kind of shriveled, you know, and they're not strong, they're very weak. It's hard for them to sit up sometimes. Okay, I'm going to change the slide now, and we're going to go to assessment of our patients on page 846. So we're going to take a good health history. Why are they here? What's the reason that's related to musculoskeletal disorders? Aches, pains, joint swelling, stiffness, and these are things we want to ask our patients. Do you have stiffness, especially in the morning, they'll say. Do your joints swell? Do you have pain? Yeah, all over, they might say. Generalized weakness, a change in appearance that is significant to the patient, and a change in the ability to carry out ADLs. So maybe that's why they're there, because they can't even do their own ADLs anymore. How about their present health? Are they fatigued? Do they have malaise? Anorexia, remember what that word means? Loss of appetite. Weight loss, pain, stiffness, edema, dysphagia, trouble swallowing, or dyspnea, shortness of breath. They get short of breath on exertion. Be aware that many cultures react differently to pain and disability. Some may be stoic, whereas others are very expressive. So what's their past health history? Now this is important because we got to find out what's happened to them in the past. What's happened in the past may reflect on what's happening now. So a detailed health history, signs and symptoms are insidious, because what that means is that, you know, it sneaks up on you. It's been happening over such a long period of time, you don't even realize it. Like, I can't even touch my toes anymore. When did that happen? I don't know. It just kind of was insidious. It just started happening. I used to be pretty flexible, not so flexible anymore. It just happened. And I exercise, but not that kind of exercise, I guess. Also, it may affect their way of life. Either they're in pain or they're not flexible, they can't reach things anymore. But they may just have somebody do it for them. So they don't really, they just kind of accept it as something that's happening. So it's helpful to have a family member there to assist the patient as a historian, because they may not remember when this started happening, but maybe the family member does, because they're good historians. Inquire about their past medical and surgical conditions. Now this is important because you want to know, have they had any history of TB, diabetes, gout, which we're going to talk about, arthritis, we're going to talk about, rickets, we're not going to talk about that, but we know that that's dietary deficiency that affects the bones. Maybe when they were younger they had that. Infection of bones or joints. If they had an infection in their bones, it's really hard to get rid of infections in the bone. I'm going to talk about that when we get to diagnostic tests. Autoimmune diseases. Now, what does autoimmune mean? You're attacking yourself. And neuromuscular disabilities. Did they have any? You know, I once knew a friend, this is interesting. I have a friend, he grew up in India, and he had polio. Well, his parents didn't want him, he had one leg shorter than the other. So they thought, well, let's cut the longer leg to match the shorter leg so that he'd have two legs the same length. But unfortunately, they did it when he was young. So he grew, and one leg, the leg that got cut, didn't grow, but the other leg grew. So now he still has a limp, and he's 60-some years old. Just goes to show you. Sometimes you don't know. Think you're doing the best for your kids and for yourself. So I digress. Let's go on. All right. So we want to record the dates of immunizations for polio and tetanus, because both of those can be characterized by musculoskeletal symptoms like lockjaw. It's tetanus, right? That's a muscle. Note pre-existing cardiovascular problems, hypertension, coronary artery disease, congestive heart failure, cardiac defects can affect the patient's ability to tolerate surgery and recover successfully. Now, what if they have a valve that was leaky and maybe they had a valve replacement? Well, you know, that may affect how they can do activities. And if they didn't have it replaced, that too affects their ability to function. So let's do a review of the psychosocial background of the patient, and if they can tolerate treatments and procedures, how they've done in the past tolerating things. Do they have fear or anxiety about anything that maybe is going to be done during this admission? If they're about to undergo an amputation, they might have a lot of fears and concerns about the surgical procedure and the loss of a body part, because that's a loss of independence, and also pain and disfigurement, which is affects our self-esteem as well. So how about accidents and injuries? Did they have any in the past? Were they a car accident maybe, or maybe it was a sports injury when they were a teenager? Low back pain. Maybe it was a result of an injury, or maybe it's just something that's gradually come on. Inquire about participation in sports and type of work the patient has done in the past. Was it a physical kind of a job or a desk job? As it says here, many types of sports injuries result in osteoarthritis in later life. And that's true. Imagine if they were a high jumper or track and field and were running, it would affect their joints. So I'd like to talk here about, and it's in another place too, but I want to talk about it because it's pretty important. So if I mention it twice, it's okay, right? So sometimes when you have an injury, fluid accumulates in the joints, and it has to be aspirated or taken out of the joint because of swelling of the fluid. So have they had that done? Did they have fluid taken out? And if they did, if they can remember, what was the color? Because it's supposed to be clear. Now, if it's cloudy, that means there was an infection in the joint. So they might have to be on antibiotics for that. And we're going to talk some more about that. So let's go to current and past medications. So to take over-the-counter drugs or alternative therapies, herb supplements, any home remedies, like the rubs, lots of creams that you can put on for muscle aches and pains now, icy hot, and some of those creams that smell. Also, besides that, do they take any drugs like corticosteroids? Now, sometimes anti-inflammatory drug is cortisone, right? And if you have an inflammation in a bone, or maybe your back was hurting, they might put you on steroids. Or you might get an injection of steroids. So that's important to know. It's also important if you take oral steroids for anything. Also, what about an inhaler? Some inhalers have steroid in them, don't they? So, do they inhale? Do they have asthma? So you can ask them, do you have asthma? What do you take for your asthma? And then you find out their inhaler has steroid in it. And we know that steroids can make you susceptible to infection. So maybe not so much an asthma inhaler, but oral steroids for sure can make you immunosuppressed somewhat, especially if you take large doses. If you had COPD and you're on large doses of steroids, it's going to make you immunocompromised. So we want to know all the drugs that they take. I'll tell you another funny story. So the other day, my husband was going to take a sleeping pill, and he took a white pill, and then he realized it tasted funny. And guess what? It was a steroid pill. It was cortisone. So he woke up the next morning, and he felt great, not one ache or pain. And he was shocked that he felt so good until he realized that he took a steroid by accident instead of a sleeping pill. I think that's funny. He felt so good because steroids, they do. They take that pain away, that inflammation in your joints or bones. So it's really an amazing medication. But remember, we do release our own cortisone, but it's just, it's always there. So when we get an extra bump with a pill, it even makes us feel better. All right, let's talk about family history. Is there any conditions that would lead to amputation, like diabetes, hypertension, or vascular diseases? Find out if the patient has a relative, because some things are hereditary. So it's important to know about their past and their family. So did they have, anybody have rheumatoid arthritis, gout, scoliosis? Remember what scoliosis is, a curving of the spine? Because these are genetic. A functional assessment. So How's their diet and fluids, their salt and alcohol intake? Do they smoke? How's their exercise? And so if you say, do you exercise? And they say yes, that's really not enough information. Because some people think walking around and dusting the house is exercise. But it's not. Walking your dog around the block is more exercise than walking around the house. So be sure you specify what kind of exercise do they do. How are they resting? Do they have to rest in the middle of the day and take a nap? Do they have to, when they exercise or when they do an activity, then do they need to rest? How's their sleep habits? Do they sleep okay? And find out their usual activities. And then you'll notice those bullet points under functional assessment. How does this problem, whatever problem it is they're having, affect the way you live? Does it affect your ADLs? Have you had to change your everyday activities because of it? Because of your feelings, because of your problem? How do you feel about any changes that you've had to make? What have you found helpful in adapting to these changes? Well, I know I'm not so steady on my feet as I used to be. I can't reach for things like I used to. I guess I'm going to be using myself as an example now that I'm an older person. But now I have to get one of those little ladders to reach things because I can't stretch the way I used to. And maybe that's what your patient will say as well. So the next column, the next page, how do you carry out the treatment program prescribed by your physician? How's that going? Is it working good for you? Or if it didn't work good, maybe that's why you're here. Has your treatment plan been effective? And what type of support systems do you have at home? So do you live with someone? Do you live alone? Do you have family that check in on you? Do you have maybe a home health nurse that checks in to be sure you're doing okay? Especially if their ADLs have been affected, maybe someone needs to come in and help them take a bath or get dressed. Okay, now let's move on to physical exam. So under physical exam, it's really important that you inspect them, inspect your patient. And you're going to check for any abnormalities. This is really important to remember in a physical exam inspection. Check for abnormalities. Check how their body is built. So like, are they scrawny? Are they muscular? Are they straight or curved? How are their muscles? Are their muscles strong or weak? So we might want to measure their height and weight because, you know, as you get older, you do shrink. You've probably heard that. Well, that's because of the loss of between the vertebrae, you lose some of that fluid. So your spine does shrink. You lose about an inch or so. And vital signs, of course, we want to take. And we want to check all the pulses to see if they have equal bilateral pulses in their wrists and their feet. We want to check hypertension, their blood pressure, which is part of their vital signs. Are they obese? Because many patients that have arthritis have limited ability to stand and sit and get up and down, so they aren't as active, so they tend to gain weight. So sometimes obesity is related to inactivity because it hurts too much. So throughout the exam, evaluate the neurovascular status, remember to document all of this, especially on admission, their skin color, their texture, the skin texture, temperature and turgor, are they hydrated, dehydrated, the overall color and condition and temperature of the skin. It's a good indication of blood supply to the extremities. So this next sentence here, cool or cold, clammy, mottled skin is pale or cyanotic, may indicate poor blood supply. Well, that's important to know because maybe that's why they're there. Because they have a poor blood supply, they haven't had enough supply to even their bone. Maybe they're there for amputation. Palpate both legs simultaneously, making it easier to detect circulatory differences. Is one leg cooler than the other? Is there any open areas on the skin? Describe skin lesions and drainage. Any wounds that are open? Palpate the pulses, presence, quality, and symmetry. Are they equal? Are they strong? Are they palpable, and where are they palpable? Pedal pulses, posttibial pulses, popliteal pulses, radial pulses. So you want to be real specific. I like that in documentation. It's very helpful when you look back. Also, we want to, if you can't get a pulse, maybe your facility has a Doppler, because a Doppler can pick up a pulse, even if you can't palpate one. So, you know, that Doppler will go whoosh, 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 give that whooshing sound, and that means there's blood flow. That whooshing sound is a pulse. So Doppler could be used. Check your cap refill of your patients. And we're going to check that for 3 seconds, right? Because in extremities with a diminished supply of blood, capillary refill might take 5 seconds or longer. So you know, when you say 3 seconds, is it really 3 seconds? Check it. All right, check the sensation by touching extremities. Can you feel this? Can you feel this? Can you feel me touching you? Where am I touching you? So don't say, am I touching your arm? Because they'll go, yeah. So kind of test them. Where am I touching you? Also, we're going to assess to move each extremity through range of motion. But don't extend the joints beyond their range of motion, because we might hurt them even more. And remember that inflamed joints, arthritic type joints, are extremely sensitive to movement and pressure. So during movement, watch for signs of pain. So keep an eye on their face as you move their arm around. Do they wince? Make any facial expressions that let you know that that was uncomfortable. And there's another thing. So this is a really good word I want you guys to know. Crepitus. Crepitus. It's in your book on page 847, kind of highlighted. It's a crackly sound. Crepitus, you know, like the plastic, that the bubble wrap. So when you push bubble wrap, how it crackles, that's what crepitus is. And that means there's air in the synovial fluid or in the sacs, or maybe the joint isn't right, too much fluid in their joint, or not enough fluid, or there's air in the fluid. No, cracking your knuckles is not crepitus. So check for crepitus. That's really important. Okay, good word. And then let's move on to collecting data about their mental and emotional status. And jump down to nursing assessment of the patient with a musculoskeletal disorder. Box 43.2. Next page. So let's look at that right now. It's what we just did, but it's repeating in smaller amounts. Sorry, had to take a drink. Okay, I'm gonna repeat maybe a few things. So look at your health history. Why are they there? Present health, does their condition affect their ADLs? Do they have pain, swelling, tenderness? Injuries because of accidents or falls? Do they use assistive devices, a cane, a walker? Their past history, hospitalizations, operations, trauma. Maybe they broke a bone in the past. We need to know that. Hypertension, coronary artery disease, those are always important because they affect the whole body, and they're probably on medication for those things as well. Congestive heart failure may show us edema. Cardiac murmurs or defects, phlebitis, inflammation of the vein. Varicosities, so are their veins like curvy, prominent? That's a varicosity. It's protruding veins that they look like a road, curvy road. Thrombosis, clots, emboli. Did the clot move? Stasis ulcers. So that's where the blood flow is not great. So it's static. It doesn't move. Stasis ulcers. And that's from a lack of blood flow. Diabetes mellitus, TB, polio, gout, arthritis, rickets, neuromuscular disorders. And again, we want to ask about asthma or any respiratory disorders because are they taking steroids for that? Important to know. All right, family history. Is there a family history of diabetes or hypertension or vascular diseases or rheumatoid arthritis? We're going to call that RA from now on. Degenerative arthritis. Did they ever have joint replacement surgery? I mean, I have met patients who've had 2 knees and a hip replaced. I'm telling you, I don't want any joints replaced. It's rough surgery. But you got to find out. Have they had them replaced? And there's many reasons to have joints replaced besides falling. You know, maybe they used it too much, or because of their past health history, or injuries. Also gout, scoliosis, and autoimmune disorders. Functional assessment, their diets and fluids. Do they drink alcohol or smoke? Do they exercise? Their rest and sleep habits. Do they need to take a nap? And after exercising, do they have to rest? You know, we take those things for granted sometimes because we just keep moving through the day, right? But some people can't do that. They have to rest. How are they sleeping? Are they sleeping through the night? Are they sleeping without medication? What was their job? What did they do? Were they on their feet all the time? And maybe that can explain some of their bone muscle injuries. What were their roles and responsibilities, and how did they carry out their ADLs? And then the physical exam, your height, weight, vital signs. Check their posture, their body build, their balance and gait, of course, because we want to know. Remember the last, should I say this? Yeah, I guess it was on your midterm. The sit and stand. So can they get up and go, I think it was called. Get up and go. Can they get up and go? So when they're sitting in a chair, can they just stand up without any problem? They don't have to hold on to anything, and they don't lose their balance. That's a get up and go. All right. Can they do that? And check their skin, their pulses, their pain. Where is that pain? And on a scale of 1 to 10, what is it? What brings the pain on? When they move their arm, that when they move their arm up, they get arm pain. But when they put it back down, no pain. You need to know those things. And then what alleviates that pain? Do they have a loss of sensation of hot or cold? Joints, is there any warmth, redness, or swelling, or tenderness? Nodules? Crepitus, crickling, crankling noise. How's their hand function? Upper extremities, are they equal? How's the range of motion? Lower extremities, how are their hips, knees, and ankles moving? How's their skin condition? Is it cold, mottled, warm? Both are warm, both legs are warm equally. Their level of consciousness, alert, oriented, person, time, and place. Their emotional state, are they kind of down? Oh man, they're here. They're going to get some procedure done. They might kind of be down about that. Can they follow directions? Maybe they're confused. How are they coping? How about family? All right, so did we talk about diagnostic tests and procedures yet? No, we have not. So I'm going to change the slide. I'm at school right now, so I'm in a room by myself and everything's kind of spread out, so bear with me here. All right, diagnostic tests and procedures. So arthroscopy. What's an arthroscopy? So that's where they take a scope and go into a joint and take a peek. A scopy, they're going to look. Arthro in the bone, maybe in the knee, an arthroscopy of the knee. They want to see what's causing the pain, what's causing the crepitus. Is there fluid in the joint when they look in there? And if there is, are they going to take that fluid out? They're going to aspirate the fluid from the joint. And if they do that during an arthroscopy, what color is the fluid? And if they need to be on antibiotics. Now, if they have a bone infection or a joint infection, they're going to be on IV antibiotics. It's not a PO because it's too hard to get into these spaces because of the lack of blood flow. So they'll be on IV antibiotics. Now, the most common IV antibiotic, this is important to know, for bone infection is gentamicin. Now, gentamicin can cause a lot of other problems. It can cause hearing problems, ototoxicity, it can cause kidney problems. But maybe they were on IV antibiotic gentamicin for an infection in their bone. So knowing that gentamicin has problems can cause problems in itself, unrelated to solving problems. So you want to check their renal function. Are their kidneys okay? Is their creatinine, their serum creatinine specifically, I want you to remember, because the serum creatinine is really what tells you if their kidneys are working well or not. It's the best test. So check their renal function after gentamicin IV antibiotic that they got from a bone infection. Really important to remember those things, guys. All right. So lab tests. So let's kind of jump over now to page 849. I know I have 848 there. But I'm kind of over some of the vascular studies, the pulse volume recording, the thermography, Doppler ultrasound. Interesting if you want to read about it. Go right ahead. But I really want to get to the diagnostic tests and procedures. So let's look at them. So check your agency procedure manual for diagnostic tests and procedures. Always tell the patient what to expect when tests are ordered. Explain if nothing by mouth or NPO, why that is. Document your assessment. If your venipuncture is done, apply a dressing and check the site for any oozing. Apply pressure and elevate the arm if patient's on blood clotting medication or if it's impaired. Because remember, we make blood cells in our bones, so maybe we've got some thrombocytopenia going on and we don't clot so well. So the first test is a blood test that I want to talk about. That's the first one in table 43.1. So that's the anti-nuclear antibody, or ANA. And I put that up on the slide, ANA. You need to know that. That's why it's in red. Anti-nuclear antibody is what it stands for. So the reason they would draw that is they're checking for lupus, rheumatoid arthritis, scleroderma, Raynaud phenomenon, Sjögren syndrome, and necrotizing arteritis. Now, what's important for you to know is the patient preparation. They need to fast for 8 hours before the test. So NPO for 8 hours. Now, like I said, this is really a good test for rheumatoid arthritis, ANA. Good thing to remember that. So I'll briefly touch on some of these other ones. The C-reactive protein, or CRP, detects inflammation. The creatinine assesses your renal function. The erythrocyte sedimentation rate, or ESR, sometimes just called SED rate, determines inflammation. Red blood cell count, so they're going to check your blood for any blood dyscrasias. And all these are found in bone muscle problems. This says rheumatoid arthritis and lupus. Rheumatoid factor, RF. So if they suspect you have rheumatoid arthritis, they're going to check for antibodies. VDRL, measures antibodies to syphilis. Now, maybe you think that's kind of funny, but you know, I know we don't have syphilis much anymore, but some of our elderly were exposed to it possibly when they were younger. And then we have a WBC checking for infection. Always remember WBC checking for infection. Normal is 5,000, 10,000. If it's above that, there might be an infection somewhere. Sometimes it's elevated in inflammation as well. So go to the urine studies, same page we're on. So 24-hour urine for creatinine, that's measuring renal function. Uric acid, it's a 24-hour urine. Uric acid is elevated in gout, so they might be checking a 24-hour urine because they suspect gout or liver disease. Turn the page, page 850. Some other radiologic studies. I'm going to keep it on that slide there for a minute. Arthrography uses contrast medium to show soft tissue joint structures. Now, there are dye precautions there because it says it uses contrast medium. When it says that, that means dye. So we know we've always got to check if they have allergies. A CT scan, that's going to detect tumors and spinal fractures. Discography visualizes vertebral discs after contrast medium is injected into the disc. Ouch, that hurts. MRI visualizes soft tissues. So see the difference between CT and MRI? You wonder what makes you order a CT or an MRI? Well, a CT detects tumors and spinal fractures. MRI sees soft tissues, and that's really important when you're looking at shoulder injuries that may be a soft tissue injury, not just a bone injury. It can also detect, I'm talking about the MRI, detect avascular necrosis. That means avascular without vascularization, so you've got necrosis. Tumors, osteomyelitis, inflammation or infection of the osteo or bone. Torn ligaments. The nuclear scintigraphy or bone scan. Well, that's a good one to detect bone malignancies or osteoporosis or osteomyelitis, some fractures. Radiography. But let's go down to tomography. So that's pretty interesting. Tomography, and this is on table 43.1. It's not on your slide right now. Oh, yes, it is. I'm sorry, it's in red. Gosh, that's because it's important. All right, tomography provides details of structures otherwise hidden by bone. So what does it require? This is important also. It requires lying in a cylindrical scanner, assess your patient for claustrophobia. I know MRIs are like that too. They're put in a tube, but so is this, and this is important to know right now. But anytime you're put into a tube, you need to ask your patient if they suffer from claustrophobia. So the tomography, let's go back to that because it's important to know. Provides details of structures otherwise hidden by bone. Requires lying in a cylindrical scanner, assess the patient for claustrophobia, and inform the radiologist if they have that. If they do suffer from claustrophobia, there is medication they can be given to relax them. They have open MRIs. I don't know if they have open tomographies or not. Not very many places have an open MRI. They need to be shipped off to another city probably. Open MRIs are good for people who are overweight also that don't fit in the tube. They do have that available, just not everywhere. So let's go to page 851, ultrasound. That reveals masses or fluid in soft tissue. So special test, arthroscopy. Arthroscopy is a surgical procedure to visualize a joint or cavity. So they're going to look in with a scope into the joint, inform the patient that the procedure is performed in an operating room under local or general anesthesia. And you can see post-procedure, the patient will have a sterile dressing applied to the wound. Joint aspiration. So if they have fluid in their joint, they might need that aspirated, and that might need to be sent to the lab. You need to note volume, color, clear or cloudy. It's supposed to be clear. If it's cloudy, there's an infection. The procedures can be done at the bedside, so you might be able to help. They might get a local anesthetic to numb the area when they put the needle in, and apply pressure dressing to the joint, and instruct the patient to rest for 8 to 24 hours. Now, a bone density test or DEXA scan, that determines the bone mineral content. So that's usually what's done. Like I had a DEXA, when you get older, you have to have a DEXA scan about every 10 years. And I had one just before I was ready to run a marathon, because I wanted to be sure that my bones could hold up when I ran. DEXA scan checks density, bone density. And since women are prone to osteoporosis, this would be a test that should be done. Now, muscle biopsy. Ow, that would hurt too, I think. A sample of muscle tissue. Now this is important to know. So it's in red up there because I need you to know it. A sample of muscle tissue is taken to detect inflammation inflammatory reaction, as in polymyositis. Myo means muscle, poly, many, myomuscle, itis, inflammation, infection. So muscle biopsy is going to give that information to the doctor. It may be performed under local or general anesthesia. So again, polymyositis can also be muscle degeneration due to another illness. So sometimes a muscle biopsy is necessary for diagnosis purposes. And apply pressure dressing to the affected area, immobilized for 12 to 24 hours. Skin biopsy might be done to confirm inflammatory connective tissue diseases like lupus or scleroderma. Okay, let's turn the page. All right. Sorry, got to turn the slide too. Everything's not available in here, so bear with me. Okay. So before we go to physical and occupational therapy, the therapeutic measures, I want to talk about the drugs. Well, I guess we could talk about, okay, we'll talk about physical and occupational therapy. I see on the slide here it's going to put drugs third, so we'll talk about that third. So physical and occupational therapy assists the patient in making adaptations in work and personal life so that they can function. And we know physical therapy makes us stronger. Education and support. So a treatment plan, we want to be sure the patient understands. We want to get them community support. Patient's attitudes, very important. And you know, knowledge is power. So if they understand and know why they're doing it, what they're doing, there's more chance that they'll be cooperative. Drug therapy. So I want to talk about that. So there's 3 categories of drugs that are used in the treatment of arthritis. And those are NSAIDs, and you probably have heard that, Motrin, Advil. There's also glucocorticoids, cortisone type drugs. And then there's also disease-modifying anti-rheumatic drugs, or DMARDs. We're going to talk about that when we get to table 43.2. NSAIDs are the safest type of these type of drugs to relieve pain and reduce inflammation. They do not prevent joint damage or slow the progress of a disease, however. So first generation NSAIDs include salicylates like aspirin and non-salicylates such as ibuprofen. There is a COX-2 inhibitor called Celebrex that can also help for inflammation. Glucocorticoids relieve symptoms, reduce inflammation, and can slow disease progression. Oral glucocorticoids such as prednisone are used for generalized symptoms, whereas intra-articular, so you can get cortisone shots. You've probably heard of that, where people with sore joints get cortisone shots. But that doesn't last long, and you need to get it done every 3 months or so. DMARDs reduce joint destruction and slow disease progression. The first choice among DMARDs is usually the non-biologic methotrexate, but it's got some immunosuppressive issues. We talked about that, I think, in another chapter. Some other DMARDs would be Enbrel, Remicade, Humira. Now these drugs, because they're immunosuppressant type drugs, it makes the patient at risk for catching illnesses. So they don't use them just surreptitiously, you don't just hand them out. Patient really has to meet some criteria and tried other things before they get to that. And then there's always surgical treatment for degenerative joint disease, arthritis, fractures, amputations. So I want to talk about the drugs. I know we got to go back to the drug therapy, looking at the table 43.2. So important to know, aspirin can be an anti-inflammatory. I know we've talked about aspirin 81 milligrams being good for heart disease, but aspirin at a higher dose is also good for pain management. It's an analgesic. It can cause GI upset, however, right? So because it causes GI upset, what are we going to watch for? GI bleeding. And if you'll notice under the nursing interventions, one of those signs could be a dark stool, which means their stomach is bleeding or has bled a little. Doesn't mean it's bleeding a lot. Dark stool, black stool means old blood. So that means the bleeding is going to be up higher in the GI system. It's old, so it's probably the stomach. If it was bright red, it would be something from the lower intestines. All right, so important about aspirin, remember that if they do take aspirin, they could get side effects such as the GI bleed. And if they do have side effects like stomach pain even, they might try a different type of anti-inflammatory, maybe Motrin or Naproxen, something else, something in that same category, because when you start getting into the other categories, you're getting into heavier medication. So if aspirin doesn't work, that's the first choice. Go to a different type of non-steroidal anti-inflammatory. All right, then there's the COX-2 inhibitors like the Celebrex. There's glucocorticoids. Now, what's important here is glucocorticoids can suppress the immune system, especially if they're taken for a long period of time. And we know that even in asthma, there can be steroids in that, so it's important to know. So what else do steroids do that we know? You may remember this. So it can raise the glucose. It can raise the blood sugar. Steroids can raise blood sugar. And you'll see that under side effects. It can cause a rise in serum glucose. It can also cause osteoporosis. So long-term steroid dosing isn't always a good idea. It works, but you don't want long-term unless it's absolutely necessary. So under nursing interventions, it says, remember that glucocorticoids mask signs of infection. You feel so good and you can move so well, sometimes you don't know what else is going on. Observe for any unusual drainage, odors, and elevated temperature. Must be tapered off rather than stopped. So that's really important to know about steroids too, is that you don't just stop them, especially when they're at high doses. They have to be tapered. Now there's the DMARDs, or disease-modifying anti-rheumatic drugs. Methotrexate can treat rheumatoid and psoriatic arthritis. I'm not going to go through all of that, but we do know that they would need to avoid people with infections because methotrexate is kind of like a cancer drug or a chemo, not chemo, but it suppresses the immune system, which is what you would want to do if you were getting chemotherapy. Anyway, then there's Plaquenil. There's Arava. Turn the next page, 854. Arava, and that's important to know. It retards structural damage. Retards me. I know. That's a weird word, isn't it? It slows structural damage. Arava. You need to monitor liver studies. But it's really important for you just to know the name of the drug and what does it do. Yeah, we always need to know interventions too, but that's for pharmacy, right? That's for when you take pharmacology. All right, let's look at the DMARDs, the BRMs. So things like Enbrel, Remicade, Humira. Go to the next page, 855. I want you to go to anti-gout medications. So the one you need to know here is Benamid. Probenecid or Benamid. Benamid increases urinary excretion of uric acid. So this is an anti-gout medication. So if a patient has gout, they might be on this Benamid that increases urinary excretion of that extra uric acid, so it doesn't build up in their joints and cause a gout attack. So that's important to know. Benamid. Okay, we've got some other drugs on that page, and let's turn the page. We're almost done. One more thing. Fosamax. Now this is important for many reasons. So this increases bone mineral density by impairing bone resorption, which means that resorption just means that it doesn't reabsorb. It just kind of weakens. Fosamax. Fosamax is going to increase mineral density, so it's going to help with osteoporosis. Now, the thing that's important about Fosamax, and when you pass meds as an LVN, you have to know this. This could be on your NCLEX too, because it's that important. So Fosamax, nursing intervention. Take with 6 to 8 ounces of water upon arising. Nothing else by mouth for 30 minutes. And then the patient should not lie down for 30 minutes after taking. So it doesn't mean they stand up. It can mean they don't lay down. They can sit up, but they have to be upright because it can cause a lot of stomach issues and it doesn't get absorbed. So let's look at it again. Fosamax, important to know. It increases bone mineral density by impairing bone resorption. So increases bone density, good for osteoporosis. It must be taken with 6 to 8 ounces of water upon arising. Nothing else by mouth for 30 minutes. And the patient should not lie down, but be upright for 30 minutes after taking it. Okay? All right. That's it for that, chapter 43. So, oh, wait a minute. One more thing. I think we have oh, there's your list of drugs you need to know, if you want to take a look at that. But you've got these slides to look at, so this is just a note to remember all these important things. Question: which of the following is not an age-related change in the musculoskeletal system? Give you a minute. Look at that. So the answer is A, loss of bone mass. It's not age-related. Age-related changes in connective tissue can significantly impact function. There's a loss of bone mass with bone strength. Age-related joint changes are related primarily to the changes in cartilage. With age, cartilage gradually loses elasticity and then becomes soft and frayed. Water content decreases and cartilage may ulcerate, leaving bony joint surfaces unprotected and promoting the growth of osteophytes. So which of the following is not an age-related change? It's A. What did I say before? Did I say the wrong thing before? The answer is A. Cartilage increases in elasticity. I think I said the wrong thing. Okay, well, here's the question. The correct answer is A. I'm actually reading that from some information I have. So A is right. And you can go back and check age-related change. All right, thank you. I'll see you in a bit.